Good morning. I'm Dr. Cagiannos, another urologist at the Ottawa Hospital, and proud to work with this great group of physicians here, and very happy to be speaking to you this morning. Could I have my slides loaded up, please? I will be talking to you guys about screening. Nothing sort of exciting and forward-thinking as Dr. Bro has just discussed, but really an important aspect of our prostate cancer care, and something that has generated some controversy in recent years, which I will try and dispel some of that. So with regards to PSA screening, the World Health Organization has set up criteria for what diseases may be relevant for screening. And they've identified a number of criteria, of which I've summarized just a few of them. So first of all, the condition must be important. This must be something that is quite common. There's really not much point in screening for something that is very rare, that doesn't affect a lot of people. The use of resources and time and effort probably does not justify that. Secondly, there should be an accepted treatment. So there's really not much point in screening if you find the disease, you don't have the ability to treat it and to cure it. So there must be an effective treatment in order to justify screening. As well, there should be a late or early phase. What that means is that from the time of diagnosis, there should be a window of opportunity to treat and cure that patient. If you're diagnosing patients only at a stage where the disease is advanced and again cure is not possible, again that really doesn't justify the use of screening. And additionally, there needs to be an appropriate test, a test that is effective, that has been shown to improve outcomes, and that test also has to be one that is acceptable to the population. If you have a wonderful test performance-wise, but the test is very invasive, patients really don't want to have it, then again, you're not really looking at a good screening tool. So the first part, is prostate cancer an important cancer? I think we all know yes. If we look at the Canadian cancer statistics, it is the most common cancer in men. And if we look at the likelihood of mortality or of dying of prostate cancer, it is the third leading cause of cancer death. So we have lung and colorectal as the top two, and and prostate cancer is the third leading cause of cancer death. So clearly an important disease, one that I think fits the criteria for something that we should be screening for. What about, is there treatment that we can offer that will affect and improve outcome? And again, the answer for that is yes. So does prostate cancer treatment improve outcomes? And so there have been a couple of randomized trials, so these are high-level clinical evidence trials comparing radical prostatectomy or surgery, comparing them to not treating, simply following patients with observation. One large study was published in Sweden, and it showed that having surgery reduced your risk of death by all causes by 25%, and specifically risk of prostate cancer death by 38%, so effective proven treatment. A more recent study performed in the United States that was just recently updated with 20 years of follow-up showed that again, treating with surgery as opposed to simply observing and following patients, again, reduced death, all-cause death, by 20%, specifically in patients with intermediate risk or more aggressive prostate cancer. So yes, we do have accepted treatment. Do we have a suitable test? And is that test suitable to the population or acceptable to the population? I think we can all agree that PSA as a simple blood test is very easy to administer, very easy for patients to have. And does PSA improve outcomes? Is there a performance benefit of the test? Is it an effective test? So we know it's acceptable. Is it effective? And that's where some of the controversy comes in. If we simply look at what happened since the initiation of PSA screening, we can have indirect evidence that PSA testing does improve prostate cancer outcomes. So if we look at, keep hitting the wrong button, I apologize. If we look at this curve here, this shows the likelihood of dying from prostate cancer over a number of years. So PSA screening was introduced in the mid-1990s, early 1990s in the US. And if you look at this curve here, ever since the inception of PSA screening, the likelihood of dying from prostate cancer, I'll show it on that graph as well, the likelihood of dying from prostate cancer has diminished. And in fact, over those years, the risk of dying from prostate cancer has been reduced by 45%. So this is indirect evidence that since PSA screening, something has happened to improve prostate cancer outcomes. This doesn't address whether it was exclusively PSA screening and maybe better treatment and some other things, but essentially, since the inception of PSA testing, less men are dying from prostate cancer. So in 2009, two very much awaited large clinical randomized trials were published looking specifically at the role of PSA testing. So these were randomized trials looking at patients who were either assigned to PSA screening or not. And they compared the outcomes of these patients with regards to developing prostate cancer and prostate cancer death. The first of these trials was the prostate, lung, colorectal, and ovarian cancer. This trial was actually negative, and this is what leads to some of the controversy against PSA screening. This trial, however, was set up for failure from the beginning. This was a trial conducted in the United States where the group of, so again, it was supposed to be a comparison of men who were screened versus men who were not screened with PSA. However, because of the climate in the United States, I'm not talking the weather climate, but the attitudes about patients and physicians about PSA testing, the group that was supposed to simply be followed and not receive PSA testing did get PSA testing. In fact, 90% of patients in the arm that was supposed to not get screened did get screened. So this really was a comparison of screening with PSA versus screening with PSA. And basically, they compared two apples and said, there's no difference. So the fact that this study came out and was negative is really no surprise to those of us who know the research and know the data. So we can simply ignore that study. However, there was a second trial that was published at the same time. And this was a European study that was much better conducted and gave very different results. So this European study was a large study. Over 160,000 patients were included across 7 countries in Europe. These patients were followed with PSA testing every 4 years, and patients had a biopsy if their PSA was over 3. They looked specifically at patients between 55 and 69 years of age. And this study showed there was, in fact, a significant reduction in prostate cancer death. 21% less death from prostate cancer in the group that did get PSA testing versus the group that did not have PSA testing. Importantly, so again, 21% reduction in the likelihood of prostate cancer death. 1 death from prostate cancer was avoided for every 781 patients who were screened, a very acceptable number. And furthermore, 1 death from prostate cancer was avoided for every 27 patients that were found, that were diagnosed by PSA testing and then treated. So clearly, an effective test does exist in PSA. So this all sounds wonderful. However, a big wrench was thrown into PSA testing and into screening when in 2012, the U.S. Preventive Services Task Force came out with this statement arguing against prostate cancer screening. And this really created a lot of public uproar. Subsequently, the Canadian task force also came out and said that for men between age 55 and 69, they did not recommend PSA testing. So these 2 large bodies came out and said, don't use it. It's not a helpful test. In fact, it's potentially a harmful test. Well, there seems to be a disconnect here between these 2 statements and the data that I just showed you. Why is that? So the argument that both these authorities used against PSA testing was not so much that PSA testing didn't find cancers and reduce the risk of death, but they felt that the harms of prostate cancer treatment, screening, outweighed the benefit. And there are potential harms of screening, and you may ask, well, what's the harm in doing a diagnostic test? And the reason for that is that not all prostate cancers are what we call significant. Not all of these cancers are destined to be lethal cancers and cause men to die. Some of these are much more indolent or unaggressive cancers, and the detection of these cancers may be referred to as overdiagnosis, overdetection. These are cancers that don't really need to be found. And as a result of this overdiagnosis, it can result in overtreatment. So treating these cancers that are non-significant may lead to all the side effects that we know can occur with treatment, erectile dysfunction, urine control problems. And these are the harms and the dangers that the task forces felt really made PSA testing not worthwhile in doing. However, that is a flawed approach to accept that there is some harm with testing, but as a result say, don't test at all, well, what about those higher grade, more significant cancers that are being found by testing? And so to adopt a policy of not screening because you're concerned about finding cancers that don't need to be treated really equates to throwing the baby out with the bathwater. You are throwing out the high-risk cancers that are significant, that need to be treated, that need to be diagnosed early. You're throwing those out with the low-grade cancers. So this seems a very flawed approach. And really, the better way to deal with the harms is not to avoid using a test that has been shown to reduce the likelihood of dying from prostate cancer, but to simply uncouple automatic diagnosis with treatment. We don't have to treat every single man we diagnose. We can differentiate between men who have lower grade cancers that are unaggressive and not destined to be lethal, and follow those along. Follow them on what's called active surveillance, and treat only those that have higher grade tumors, more significant cancers. And active surveillance is something that really has caught on. And we here in Canada and Ontario really are one of the leaders of this. In fact, Dr. Morash was the lead in a guideline that was published by Cancer Care Ontario that has been adopted Canada-wide, has been endorsed by various national and international bodies of really following patients with low-grade Gleason 6 cancers. And we here in Ottawa will follow or not treat about 70% of our patients with low-grade cancers. So you can uncouple diagnosis from treatment, and we have been very effective in doing that in Canada and specifically here in the Ottawa region. And so the large American Urological Association and Canadian Urological Association bodies so are really the thought leaders in Canada and the US of urologic community, continue to recommend and advocate for PSA testing even after these guidelines came out from the US Preventive Services Task Force and the Canadian Task Force. And so the AUA continue to recommend PSA screening in men between age 55 and 69, avoiding screening in younger patients and in older patients. And similarly, the Canadian Urological Association, the CUA, also continues to advocate for PSA testing in men over the age of 50 with a significant life expectancy of over 10 years. And that's important because we do know that prostate cancer is a slow-growing cancer, and if you don't have a long life expectancy, the reality is prostate cancer is not the most significant health concern you have. So if somebody's young and healthy, then PSA testing is still recommended. Typically, PSA testing is suggested to be annually, but they have brought up some other alternative approaches, perhaps screening every 2 to 4 years. And what's interesting is the US Preventive Services Task Force has started to listen. In fact, in April, they came out with a draft guideline where they've updated their recommendation, and they've now moved away from arguing against PSA testing, saying it's a harmful test, to now basically saying it should be discussed individually with physicians and their patients. So I quote, "The potential benefits and harms of PSA screening are closely balanced in men 55 to 69, and the decision about whether to be screened should be an individual one." And this is called the Grade C recommendation. So they've updated their criteria to now no longer be publicly saying that PSA testing is harmful and it should not be done, to one that, you know, there are potential benefits now that need to be discussed with individual patients. And this was really a major step forward because that statement was affecting the way that family physicians specifically were screening for with PSA. And we feel that that potentially could harm patients with regards to eliminating diagnosis of significant cancers. The benefit, however, of these task forces coming out and saying initially don't screen, again that's been updated, is that it did make us as a urologic community evaluate what are we doing. Sometimes it's good to be challenged and not just continue with the status quo. And this really made us look at PSA testing, how we use it, are we doing it appropriately, are there better ways to consider PSA testing. And there has been some very good research done in this. There was a large study done in Sweden, another one in the US, looking at the role of earlier PSA testing, doing a PSA test in midlife, in the 40s. And this would establish a baseline risk for future development of prostate cancer and of lethal prostate cancer. And these studies have shown fairly similar things, that if you have a low PSA, less than 1 in your 40s, your lifetime risk of developing a lethal prostate cancer is actually extremely low. And that may allow you to have much more liberal PSA testing. So instead of having annual PSA testing, you could have PSA testing every 5 years. And so it allows patients to sort of be selected for who's at higher risk and who needs closer monitoring versus who can have much more liberal monitoring. And furthermore, at age 60, if your PSA is very low, you can no longer even require any further PSA testing. In fact, if your PSA is less than 2, your risk of developing cancer is very small. But if it's less than 1, your risk is almost 0 of dying of prostate cancer at age 60. So you can terminate PSA testing at that point. And so really, the summary is, it's in the way that you use it. Like everything that we have, the tool is only as good as the individual using it. And if you know how to use PSA intelligently, the data supports that it does reduce death from prostate cancer, is an acceptable test for patients, and it's one that really should continue to be the mainstay of our screening efforts. And I think it's an important test that we continue to advocate for. Thank you very much.